Welcome back to Sensible 2020. I'm your event host, Seth Adler. Thank you so much for being here. It is my honor and pleasure to be here as your event host. This next panel is a great one, designing a healthcare system for people who use drugs. You might hear my dog in the background. That is of no matter. Your host for this session is Allie. Allie, please take it from here.
Hi, everyone. Thank you. I want to extend a big thank you to all of our panelists. Everybody who's on this panel right now is an essential worker. We're in the middle of a pandemic. So the fact that they decided to make time for this is a tremendous gift to this network of people. I'm really grateful for you for being here. I am an EMT in New York City, and I do a lot of work around altered states, the intersection of altered states in the criminal justice system. How can we get the criminal justice system out of healthcare, and how can we better support people in altered states? And if you could all introduce yourselves, that would be wonderful. I guess I'll call on you since it's a different order for every person. So how about Laura, can you go first?
Sure. Hi, my name is Laura. I'm a social worker in Baltimore City. I work with Meredith at a Suboxone program, and I work in an inpatient psychiatry unit in a hospital, and lately sometimes in an emergency room. I use she, her pronouns, and I'm excited to be here. Thank you for having us.
Yarelix, can you go?
Sure. My name is Yarelix. I work in New York City. I did not get approval to disclose where I work, so I'll just say that I have worked with people who use drugs in both hospital settings and in government settings. I use she, her pronouns, and I'm also excited to be here.
And Meredith?
Great, thanks so much. Thanks so much for having us. And thank you for everyone who's watching this. My name is Meredith. I am a nurse practitioner. I'm a Suboxone prescriber. I work with Laura at a community-based Suboxone program. I also work at the Baltimore City Health Department on a mobile truck that provides care to folks who are using drugs as we co-locate with the city's needle exchange. And then I'm also a primary care provider in a large institution in Baltimore. And I use she, her pronouns.
Thank you, all of you. So the first question that we have is, can you describe some of the work that you do with people who use drugs and how that is being impacted right now by the pandemic? Laura, would you like to go first?
Sure. So Meredith and I work in a Suboxone program, community-based, and right now our program is almost all virtual. So we're doing telephone check-ins. We just had our first virtual group, which was really special and fun to hear everyone's voices together. But so I think the biggest change for us has been that we're now interacting with people almost entirely by phone and not having that same kind of group experience. So I think that's been tough, and Meredith can talk maybe a little bit more about our changes to prescribing if that's something that would be relevant or interesting to others. And then I also work in a hospital in an inpatient unit where things are, at least in the psychiatry department, relatively unchanged right now.
So I'm going to talk a little bit about my previous work as a research assistant in a hospital in Baltimore City, where I worked at like the substance use unit that was specifically for people who use drugs. And I currently work as kind of a consultant role as a research scientist. I do outreach and harm reduction work around overdose prevention in the city. While we're doing outreach, we also collect research on what's going on in order to create a rapid response for what would be appropriate for people that are facing extenuating circumstances like a spike in overdose, spike in emergency room visits, and creating some kind of like community plan to help whatever crises tend to come up as they come up in the city.
I think right now the biggest issue, the issues for healthcare and folks who are using drugs is access, and access to high quality healthcare is always an issue. I think this is a much larger issue right now. I think most programs are closed to new patients coming in. And so access to, any type of drug treatment and getting kind of enrolled into a program is really, really challenging. And while programs say that they are open, I think that there are so many barriers to jump through when patients are trying to, access these programs. And so I would say that every program that I'm in right now, if you are a current patient, there are kind of many changes to the laws that allow people to continue to get healthcare. And so we're able to provide healthcare to folks that were already enrolled in our programs. But for people who are really trying to get into a program, it's really, really challenging. The other issue that we're seeing is that the drug supply has changed. And so it's harder for drugs for people to, buy drugs for many reasons. There's a change in the quality of drugs that I'm hearing about. There's a change in the prices. People have kind of less access and more access to money right now. It's a little bit of a strange situation for a lot of folks, but a lot of things are changing. And so people are wanting to have more access to Suboxone and methadone and just other like drug treatment programs right now. And it's really hard to get into those programs. Yeah, that's kind of the biggest thing I'm thinking about right now.
Yeah, and piggybacking off of that, another thing that we wanted to ask you all is in general, and not just only during the pandemic, but in general, what are some barriers to accessing healthcare for people who use drugs? What ways are people normally denied care, and how is the needed care not being understood well by providers? So Laura, if you want to take that first.
Sure. So I think there's a lot of things, like an unending number of things. So it's hard to know where to start, but I will say a couple of them, and then I'm sure that the other people on the panel will also say a couple, and then we'll hit on a few. I think that a few that really stick out for me, one is insurance. Meredith and I are lucky enough to work in a grant-funded program. And so we see patients through insurance changes. Frequently, people come in without insurance, or someone will convert to having Medicare, and in other settings that would require you to either be excluded from care or for you to have to change your provider, which can be very disruptive if you are established with a healthcare provider and having to change that because of your insurance is very stressful. And I think that, I'm glad that we're grant funded, but in a lot of ways, I wish that all services existed in a way that people could come in regardless of their insurance type and remain in the program through lapse in insurance, or we could just like do away with the insurance system in general, which would be great for all people, including people who use drugs. I think the other piece that really sticks out to me is criminalization. I know that it's really stigmatizing, and one of the reasons it's so drugs are so stigmatized is because they're illegal in most places. And seeking care and being open about an illegal behavior is very difficult. Healthcare providers can often carry a lot of preconceived notions and some pretty dangerous and beliefs about people who use drugs and about drug use in general. And it can be really hard to have an honest conversation about the real risks or harms associated with drugs use because it's illegal.
Current work, we do a lot of attempts to do systems change work by engaging systems that interact with people who use drugs. So this includes drug treatment programs, pharmacies, syringe exchange programs, like a variety of people that intersect with people who use drugs. And the problems that we see is that a lot of these programs, except for syringe exchange programs, are not harm reduction oriented. And so when there's people who use drugs that are not ready to be completely abstinent, they go to these hospitals or they go to treatment centers that are not understanding where they're at. And that is very off-putting for them because of the stigma, and also just the programming is not made in such a way that is inviting for them to want to stay. And so a lot of people end up, losing hope or having a really bad issue with like an overdose or like abscesses or things like that, and then ending up in these treatment centers where they're treated very badly, and then they end up leaving and not receiving any kind of care at all. So part of the work that we do is trying to implement harm reduction strategies, or like engaging and using harm reduction as a framework for the work that all systems tend to do, which like a lot of systems just don't embrace that. And another issue that we see is there are, like in New York City, there are syringe service programs that are obviously engaging in the harm reduction model, but they're extremely underfunded. Like they're not getting the care that they need. They're not getting the funding that they need. Their employees are not being treated properly because they just don't, they're just being burned out in a system that isn't helping the people that they're supposed to be caring for. So between the whole system being not harm reduction oriented and like very stigmatizing, and like the bit of services that are allowed to help people use drugs just not being funded properly, there's a lot that needs to be done, like in a broad sense.
There's so many directions that we really can take this question. I agree with everything that was said before. When I think about kind of how the healthcare system interacts with people who use drugs, the biggest thing that comes to mind is that there was a shift where, drug use was a criminal issue. And then all of a sudden, we saw the shift with the opioid epidemic, and a lot of this has to do with race, and white folks were dying kind of more. And so then it was like, oh no, drug use, well, actually more specifically, the overdose epidemic was a public health issue. And now we see this rhetoric starting to change. And so we have a realm in the medical system right now where we are, we've kind of like taken over in so many ways the criminalization of drug use. I don't know if I'm being clear, but and so in so many ways, instead of like sending folks to jail, we're sending folks to treatment. The issue is in that treatment, as Yarelix said, most of these programs are not harm reduction based. They're still abstinence only. We require drug testing. We require oftentimes insurance. And for the few programs that are grant funded, we still have to get those grants. We often require IDs. We require some amount of stability in someone's life so that they show up to an appointment. We still require people to engage in a system that was never designed to kind of care for them. And in so many ways, the healthcare system is designed to control. And so it's to control people's drug use. It's to control, what the public deems to be like inappropriate behaviors. And so I think that's probably like the biggest structural barrier that I see, is that the way that it's set up from the beginning is not actually designed to make, folks who use drugs healthier, or really to educate the providers in how to actually properly properly treat people and care for them.
Thank you. Yeah, I want to add to that there are a lot of similarities between our current healthcare systems and our carceral systems as far as people who use drugs are concerned and people who are in altered states. There are parts of the country where almost half of the emergency room visits come from methamphetamine psychosis. And people are given other medications without their consent. They're not allowed to leave rooms. Currently, there's a directive that just came through. I'm not sure how it's going to be implemented yet, but in New York City, as far as transfers of patients go, all patients who are altered mental status patients are going to be covered with face masks, whether or not they show respiratory symptoms. And that's pretty much the opposite of de-escalation in terms of, patient interaction. And when somebody's in an altered state, they're often confused, they're often, scared. And the last thing you want to do for that patient's well-being is to kind of come in there and take over their experience that way. So it feels a lot like the convenience of getting somebody out of the public sight takes precedence over patient care still. So there's a lot to be said about that. In New York City alone, almost 200,000 calls per year of just people with altered mental status who then interact with law enforcement. That's a big way that people are interacting with law enforcement who otherwise would not, including people who have not taken drugs. Many people who are experiencing other kinds of altered states enter the system this way as well. So having put my spiel in there, I wanted to piggyback also something that Meredith said, ask another question of you all, which is, what are social determinants of health? How do they play a role in healthcare access? And how do health programs for people who use drugs navigate providing care to people living at intersecting points of marginalization? Laura, please start.
Okay, I feel like everyone else is so much more articulate than me. I was like, but so, I mean, it's a really good question, and it's a big question. It's like a really big question. And I think that in Baltimore and the people that were the patients that we're working with in our programs, there are a lot of things that affect people's ability to, to want to be in a program or to be able to be in a program. I think that that there's a huge overlap with the healthcare system and the way that they treat people who are impoverished, and the role that poverty can play in healthcare access and in healthcare. I mean, even if we're thinking about some of the directives around the social distancing and the pandemic, I think that looking at what's happening in homeless shelters or what's happening in houses that have, where if a large group of people live in one house because that's what they can afford, or people who are sleeping on the street because the shelter's closed to new intakes, that there is such a gap in how, and I think that when they're looking at the coronavirus numbers in Baltimore City, the highest rate of infection is in a pretty low income district that's right next to a zip code that has some of the highest concentration of wealth in the state that has almost no infections. And that parallels to the type of care that people can access if they're looking for syringe exchange programs, or if they're looking for harm reduction programs, looking for drug treatment programs that are more abstinence-based. The type of programs that people who have private insurance can afford are very different than the type of programs that people who have public insurance can access. I think the other part that I run into a lot at the hospital is that drug treatment is often a stand-in for housing. It's a stand-in for like transitional housing, because you can get to, sure, you have to go to a few groups every day, probably more than a few groups, but in exchange you have a place to sleep that's not a homeless shelter, not sleeping on the street. And so I think the trade-off is that there's not a lot of options for people who are not really interested in an abstinence-based approach, but would benefit from housing or are interested in housing. And I think that makes it's difficult, I would imagine, as a provider, if you're trying to do an abstinence-based program and that's not what people are coming in for. And also hard if you're a patient who wants an abstinence-based program, or a patient who wants a non-abstinence-based program but would like transitional housing. So I think that there's a lot of barriers around housing, and it would just be, I think it would be in the interest of everyone if there were more options, just a variety of different options, and if housing was not an issue. Like if, we just gave people houses, or if our city provided as a community places for people to sleep that didn't endanger their health. I think that the other component that we often, that for me, working as a social worker, is that there are a lot of people who come in with underlying mental illness. And for a lot of drug treatment programs, they're great if you have a mood disorder or like a history of trauma that isn't too much affecting your life other than your substance use. But for severe and persistent mental illness or severe psychotic illnesses, there's not a lot of options for people who are interested in both I think that there's a lot of places that say they're dual diagnosis, but very difficult to actually find a program that will treat someone who has a mental illness that is severe and persistent and will have an honest conversation about their drug use.
Social determinants of health are just all the factors that influence a person's ability to be able to engage with their health. And thinking specifically about people who use drugs and also people who use drugs in this time. So generally, as far as the data that we have, last year was the first time that we had Black New Yorkers having the highest overdose rate in like 9 years since we've been recording overdose data. And then this year, Latinos were the highest overdose rate ever in the history that we've been recording overdose deaths in New York City. And when we're looking at the data in people that are dying of COVID in New York City, it's Black and Latino families. So like, there's this disparity of both, like maybe they're living in food deserts, maybe they don't have a lot of money to buy healthy foods, maybe they don't have access to healthcare, maybe they don't speak English, maybe they are undocumented, so they're afraid of going to the hospital. And for a lot of these reasons, people are not feeling safe enough to access treatment. They're not feeling safe enough to access the healthcare that they need for primary care to be able to have preventative measures. And instead, they're going when they're almost dying. And this is both for the general community, but also even more so for people who use drugs because they're at high risk because of the practices that they may be engaging in. So, when you have so many factors that are working against you because you don't have access to treatment, and there are all these problems that are not being addressed, and on top of that, the stigma that keeps a lot of people from even wanting to access treatment, it makes it really hard for a person who uses drugs that may have other marginalized identities to access that help that they may need. Yeah.
Thank you. Meredith?
Oh, there are so many brilliant things that were already said. When thinking about kind of the health of someone, there's not people come in with so many different aspects in their life, and that's to me what I think about in social determinants of health. I mean, Yarelix said it wonderfully. It's what allows people to stay healthy, and what are the things that impact someone's health. I really think about just like the racist healthcare system. And so when you have a racist healthcare system, and then you have a lot of stigma that someone has, or that the healthcare system has towards people who use drugs, and you put those things together, and now you have folks of color being treated worse, and then on top of that piled with a substance use disorder. And I mean, we know that people are offered different types of treatment. We know that people are offered different entry and like easier entry into treatment just based on their race and really where they're from, if they're homeless or not. And so, yeah, all these things definitely impact each other. I'm gonna just steal a quote from Laura. She and I once did a training, and we talked about like lowering barriers to like our Suboxone program. And Laura said really eloquently, there's always going to be barriers because our healthcare system has barriers in it. And when I think about our healthcare system, I think about the fact that it really works for people who are white, people who are rich, people who have stable lives, people who have houses, people who have jobs, people who have insurance, who have IDs and all. And so that means that if you don't have those things, that our healthcare our healthcare system it's not designed to work for you.
So I would also like to ask, what are some programs that have been implemented within healthcare systems and outside them that have worked well, in your opinion, for people who use drugs, actually meeting some of these needs, taking these things into account? What should people who are watching this know about and advocate for? And can you say a little bit about why those things are helpful? Laura?
Sure. So I think that I can talk a little bit about the changes that our Suboxone program made over the last few years. I think when we started, we were very much, there's some conception in drug treatment that even just medication-assisted treatment is harm reduction. And that largely is not the case. Harm reduction is about choices and about self-determination, and it's not about, there's a lot of medication-assisted treatment programs that are not about self-determination and your own choices. And so I think that over the last few years, we made a really intentional shift between being more abstinent focused and being a more harm reduction based program. And some of that was about working with with the leadership at our organization to make this transition in kind of like in a way that was comfortable for both the patients and for the staff. But one of the things that is really exciting about the work that we're able to do now is that we're working with being able to have conversations with people about how they want Suboxone to work in their lives, like what role do you want it to play? Are you interested in it eventually transitioning to a time when you're not using any opioids, or are you interested in using Suboxone to help reduce your overdose risk, or using Suboxone to help manage pain, or using Suboxone to reduce your use overall? Or do you want to keep using cocaine, but you don't really want to use opioids anymore? So I think like being able to have that kind of those choices. I felt when I first entered social work, I was feeling really frustrated that people were not being honest with me and about their substance use. And I was like, don't they know I'm a harm reductionist? Why aren't people just telling me? Like, I'm open to it. And my supervisor said to me, he said, if people aren't being honest with you, it's because you are not creating a space where people can be honest with you. And some of that is not just about you as a provider, but just recognizing that what are people seeing of you as a provider when they're walking into the door. And a lot of that is all the shame and stigma and criminalization that's come with decades of our drug policy in the United States. So I think that really being really intentional about how you're communicating in the space and what you're, and just like what options you're having with people and giving some time for that trust and relationship to build. I think in terms of advocacy, I think advocating around the decriminalization of drugs and making this a non-criminal issue, and also around national healthcare are, I think, probably the two areas that would have the biggest effect on the healthcare for everyone, but particularly for people who use drugs.
Thanks. Yarelix?
Yeah, so I'm going to give 2 examples, and I will preface with a caveat that I've lived in 2 cities that are probably better resource for people who use drugs because they have so many people who use drugs that there have been programs that have to be built to support people who use drugs. So this may not be feasible in places that don't have a lot of people who use drugs or that are very under-resourced in general, like rural areas. But one thing that I really liked from the hospital that I worked at in Baltimore was that there was a substance use unit that was dedicated to helping connect people who use drugs that would come into the hospital to treatment before they left the hospital. This wasn't always possible, but because that system of intense care was present, and not only were they there to connect people to resources, whether it be treatment or harm reduction services or whatever before they left, they also made sure that while they were in the hospital, they were treated well and that they were given the medicine that they needed. So if somebody came in withdrawal and they wanted OxyContin, like they did their best to connect that person with that. If they wanted Suboxone, they did their best to connect that person with that, which is so important because, oftentimes the doctors may have the stigma in like, oh, you use drugs, so I'm not going to give you the drug because you might abuse it or whatever, and so to have people inside dedicating their time just to making sure that people are comfortable, that was really important for me to see inside of the hospital system. The other system is if government can somehow get harm reduction oriented and make sure that harm reduction is somehow being implemented into the system, that would be another very optimal way of doing systems change work, because a lot of smaller organizations and drug treatment programs and things like this, like they require or they depend on funding from the government. And so the government can use that as leverage to say that, if you're not harm reduction oriented, if you're not helping people get into treatment, if you have extremely high rates of people leaving because you're not treating them properly, we're not going to give you this funding. And so like that, it's kind of coercive, but at the same time, it's for the, for the care of the people. And so if there's a way to have those in authority become harm reduction oriented and then like help others become harm reduction oriented, that's probably the best option that we have in this capitalist system, unfortunately. If there's other ways to encourage like community-based empowerment, that'd be great. But I think because funding is such a big part of the healthcare system, that's a way to push harm reduction forward to help people.
Meredith?
Yeah, I'm gonna stick with the 2 examples kind of route. So the first one is, so I work on a mobile truck that goes to various sites around Baltimore City. And when we pulled the data actually recently to look at where are people sleeping and where are they going for treatment? Most people are not traveling more than a mile to get treatment. And most people, even though there was other kind of treatment locations kind of near them, if they were over a mile, chances are they hadn't gone to that location. And so I think it speaks to a few things. One, I think it speaks to the fact that in Baltimore, because of redlining and segregation and kind of that whole history, the city has been really, really divided, and transportation is really challenging. It's also expensive. And so it's been really amazing to work on a mobile unit and actually bringing treatment to people. And that's been something that's really worked. And we've seen people just kind of walk up to a truck and get care in ways that they wouldn't have gotten before. And it was really just out of convenience. And so truly bringing programs to people, I think is really successful. I love outreach. I love outreach models. Like mobile is something that I really, really believe in. So that's the first thing that I think has worked well. And then the second thing is, in healthcare, I think that there is a real big push to create this separation between patient and provider. And I think that there are so many ways in which we kind of uphold that relationship. And I think what happened, and it is important to have that separation. I think it is important to have professionalism. Like I'm not saying kind of get rid of that, but I do think that there is something when a provider is reachable, when you don't have to go through an entire phone tree just to get someone on the phone, when you know people, they know my face, they know the entire staff's face, we know, you know who your patient is, and you don't just have kind of like a huge panel of patients where, you're just like, I can't even like envision their face right now because there's so many people that I'm taking care of. Or vice versa, the patient's like, I haven't seen a provider in so long, I don't even know who my provider is. And so I think in some ways kind of like building those relationships, every time I've seen a program have really strong relationships between the care providers and the patients, people just do better.
Thank you. I want to throw out just rapid fire some just terms we didn't get to, so that people can look them up later, and then we're going to wrap up. So things that you guys can look up at home: syringe services, education about communicable diseases, wound care, preventing infections. A lot of people who didn't come on this call, Kat Humphreys, who's very inspiring to me, does a lot of work with creating zines for people that they can take home and read and bring to their communities in various languages. Language access is also really important. Overdose prevention sites, SCS, harm reduction psychotherapy, having therapy be a part of the treatment, and then talking about Medicare reimbursement and universal health coverage, housing first, and services that are just moving beyond opiates, stimulant-specific services, subscription, and having substance use disorder being a qualifying diagnosis for receiving your substance of choice that you're addicted to as a prescription medication take home. So these are all different things that people have talked about, and please look them up.